Okay, well, it is basically 10:05, so let's go ahead and get started. And of course, as I mentioned, this is being recorded for viewing later, and I'm very happy to introduce Dr. Milewicz today, who, of course, I'm sure most of you all know, but just in case you don't, she is a professor at the UT Health in Houston, Texas, where she works on genetic aortic and vascular disease. And she is, of course, the person who found the genetic cause of SMDS and first described the syndrome, and then later has gone on to publish the only treatment guides to date for this condition. So we're very lucky to have her here and sharing her expertise and update us on what's happening with the research and this condition. So I will turn it over to her.
Great. Thank you very much, Ellen. Hello, everybody. Glad you could join today. I spoke to the group in the fall about our research studies, and I just want to give you an update of where we are in these studies and where we hope to go with this particular research that we're doing. I'm going to go ahead and share my slides and start talking about go back over briefly what I talked about in the fall, and then update you as to where we are with the studies and then where we're going with these studies, with the ultimate goal to have a clinical trial to hopefully delay and improve, delay the onset of complications and improve the outcome for the patients. I'm happy to answer questions during the talk. So if there's something you don't understand, put the question into the chat. And then Ellen, just go ahead and interrupt me if there's a question that comes up that really needs to be answered. Okay, so everybody should be able to see my title slide here. Good. So as Ellen said, I identified and described the syndrome back many years ago, back in 2010, not that many years ago, but over 10 years ago. And we went on to a number of years later to actually describe the clinical history, so that what was happening to these patients, and make management recommendations, and based on the patients that were in our research study. And we've continued to recruit patients into a study, and this will be the basis for really this sort of baseline data will be used to determine if our treatments are improving the outcomes for patients with smooth muscle dysfunction syndrome. And I just want to mention that I called it multisystemic smooth muscle dysfunction syndrome to start out with, but that's too much of a mouthful, I think. And I prefer to refer to it as smooth muscle dysfunction syndrome, or SMDS. And so I think we should drop the multisystemic and just call it SMDS, because it's much easier and much more succinct. And when you say it involves smooth muscle cells, it already describes it as multisystemic, since smooth muscle cells are in multiple organs. So these are the major complications of this condition. One is the problems with the arteries in the brain that lead to the major artery going into the brain getting blocked, and that leads to strokes in patients with smooth muscle dysfunction syndrome, or SMDS. Thoracic aortic aneurysms also occur. That's why the aorta enlarge. We know how to prevent this condition because we can monitor the size of the aorta, go in and repair this section of the aorta, and that prevents life-threatening type A dissections. And then we also know that many of the patients have problems with their lungs, and we're only beginning to understand some of that's due to pulmonary hypertension, which is actually a problem with the arteries in the lung circulation. But we also know that there's an underlying problem with the way the lungs are formed during development, and that paper is currently under review. But these are the problems that we really need to address to change outcomes for this disease. There's other complications, including with the eyes, the GI tract, the bladder. Most of those are not life-threatening. These complications are what end up being life-threatening in patients with SMDS. And so this is what we're really trying to address with anything, and the studies we're doing to understand what's occurring and causing the blockage of the arteries in the brain and the blockage of the arteries in the lungs, and then the enlargement of the aorta leading to dissection. So we have to something that's going to address all these problems and treat all these problems. So what causes SMDS? Well, it's just one change of one nucleotide out of 3 billion in the human genome. And that change occurs in a gene called ACTA2, and the change leads to disruption of a specific amino acid in the corresponding protein called arginine 179. So most of you have heard that this condition is due to alterations in ACTA2, and many of you know it's specifically arginine 179 that is altered. We actually have another paper in press, and Anita, one of my graduate students, and Kelly, one of my postdoctoral fellows that's soon to be on faculty, are co-authors on that paper. In fact, Anita is first author. And we have found a few other patients that have features of SMDS, but actually have other alterations in the gene. But by and large, the major cause in the greater than 96% of the patients is this arginine 179 change in that's due to a mutation, or as we call it, a pathogenic variant in the ACTA2 gene. So ACTA2 is a very interesting gene because it's almost exclusively expressed in cells called smooth muscle cells. And those are the cells that are disrupted in patients with smooth muscle dysfunction syndrome. So that kind of ties together. And what are smooth muscle cells? Well, we're going to focus on what they are in arteries, because that's where we're having the problems with the aorta and the problems with the arteries in the lung and the arteries in the brain. And what the arteries are made up of a they have the inside of the artery, or the lumen, where the blood flows. And then the wall is made up of 3 layers, and it's this middle thick layer where the smooth muscle cells are. And they will so every single artery is lined with smooth muscle cells, and those smooth muscle cells turn on the ACTA2 gene to make a protein, and that protein is the major protein in a smooth muscle cell, and that protein is called smooth muscle alpha actin. So the smooth muscle cells in the aorta and the ascending aorta, where those aneurysms occur, and in the brain, actually derive from neural crest stem cells during development. So as the embryo is developing into a human, the original progenitor cells, some of them become neural crest cells, and some of them then, of these neural crest stem cells, go on to form the smooth muscle cells in the arteries in the brain and in the aorta. So we really wanted to try to figure out why altering specifically this arginine causes such a severe disease and total dysfunction of all of the smooth muscle cells in the body. And we've set up 3 different model systems to look at that. We've taken fibroblasts from some of the patients with the arginine 179, this R179 alteration in ACTA2. We can take a skin biopsy, grow out cells, and differentiate them into stem cells. And then those stem cells then can go into neural crest cells and then into smooth muscle cells. And Kelly, Dr. Kortler, has been doing a lot of work to see what goes wrong during this differentiation, and I'll talk more about that in a minute. We can also take the aortas from patients in our mouse model and take the aorta and grow out the smooth muscle cells from the aortas of both patients and mice. And then we've engineered a mice in which we can introduce the mutation specifically into smooth muscle cells. And so we have these 3 model systems to study. And Callie really focused on the cellular model system and was able to show, oh, I misspelled your name, Callie. There's a T in Kortler. She's been able to show that typically this progression of neural crest to smooth muscle cells is very complete, and you turn off all the stem cell markers and turn on all the markers of smooth muscle cells in your typical pluripotent stem cell. But in patients with the ACT2 arginine 179, this transition does not completely occur, and instead you end up with a altered cell, and that cell maintains some of the characteristics of a stem cell. And one important characteristic that it maintains is that they proliferate and migrate faster than normal smooth muscle cells. And that's just shown here. We put the cells in an upper chamber and let them sit there, and over time they move down into the lower chamber. Then we can look at the number of cells down here that actually migrated through the chamber. And if we look at wild type cells, there's just a few cells that migrate in this system. And there's many cells that migrate when we look at the SMDS smooth muscle cells. So this really dramatically illustrates that these cells migrate more rapidly. They actually grow or proliferate more rapidly also. So I sort of think of them being like almost cancer-like in the way that they're modified. And it's being recognized more and more that cancer cells also revert to a stem cell-like cell as they become cancerous. I want to emphasize that this is not cancer, that this is controlled proliferation, whereas cancer is uncontrolled proliferation and migration. And so it's not as bad as a cancer, but you can think of it in terms of being like a cancer. And so based on the data we have on the alterations of the cell, we started to test different chemicals to see if they would alter this migration and alter the stem cell-like phenotype. In other words, did it start pushing the cells from being neural crest cells into and better differentiating them into smooth muscle cells? And we did find one chemical and one treatment that did. We've actually found now 2 different treatments that cause almost the same results. And so here is just showing you once again these control cells versus the migration of the SMDS cells here without treatment. And you can see there's a large number of cells in that lower chamber. But now with the treatment, the number of cells goes way down and starts to almost match that of the control cells. Interesting, this treatment also prevents the control smooth muscle cells from migrating. And all this is quantitated over here. And this is both work by Callie, but also Anita. So we can, and I'm not showing you all the data that Anita has, that this treatment alters the smooth muscle cell, but we know it decreases this migration, and it decreases the stem cell markers and increases those markers of differentiation in smooth muscle cells. So it's taking the smooth muscle cell in a direction that we would hope would help prevent problems in the patients. So in other words, it's taking the SMDS smooth muscle cells and making them more like control smooth muscle cells in tissue culture. All these studies have been done in cells in tissue culture. So we wanted to move these studies now into our mouse model. And this actually is what delayed us from starting the clinical trial. We did not think that we had, that we could actually, at baseline, the mice do not have strokes. And we had some evidence that they had changes in their arteries, but those changes did not lead to strokes. And it did not lead to blockage of the arteries like we see in patients with SMDS. And so we wanted to see, take our mouse model and see if we could do something to the mice to actually evoke the changes in the arteries that we see in SMDS patients. And I just want to remind you that here are the smooth muscle cells in the wall of a normal artery. And then there's a thin layer of a different type of cell here. And then the lumen should be wide open so that the blood can get through. And when the blood doesn't get through, that's when a stroke occurs. And this is what you see in a blocked artery in patients with moya-moya-like lesions in their brain. Here's the wall of the artery. So there's two little smooth muscle cells in the wall. These are those purplish, long spindle purple-like cells. But then when you look in the lumen, you can see that instead of being wide open, it's filled. And it's filled with a lot of cells. The little black marks are cells. I mean, the dark blue marks are all cells. And these cells stain positive for smooth muscle markers. So we think the cells in the wall are migrating into the lumen and proliferating and leading to this, this blockage of the arteries. And you can see that similar to what I was talking about previously, it almost looks like there's a tumor filling the lumen. Some of the lumen is still open here, but is almost completely blocked instead of being wide open like a normal artery is. And this is what we think leads to those strokes in patients with SMDS. So we wanted to see if we could go in and actually do a mild injury to the carotid artery where these blockages occur and see if we could actually cause lesions that look like this. And so what we did was, here's the carotid arteries coming up into the brain, and we can make a little nick in the skin and go in and just tie off the carotid artery right there in the mouse. And this doesn't harm the mouse, and the surgery is pretty mild. In fact, all they need is some Motrin after we do it to make sure that they don't have any pain. So what happens when we block the artery is, first there's a clot that forms. Then typically, even in the control mice, smooth muscle cells come out of the artery wall and go into the clot to start to resolve the clot. And over time, those smooth muscle cells resolve the clot, and there may just be a few remaining inside the lumen, but most of them die off, and you go back to having a completely open lumen. Okay, so we do this injury in the mice when they're 2 months old, and then we follow them up to 3 weeks after the injury. And in the wild type mouse, the artery should be completely reopened, and we wanted to see what happened in our SMDS mouse. And this is what we found. Here's the wild type mice, and here's the purple is that inner layer of cells, and the lumen is wide open, and you can see the cells in the wall. Over here is our SMDS mouse. Here's the wall. First of all, the artery is much bigger than it is in the wild type mice, and the wall is still there. You can see here the pinkish, dark pinkish is still out here, but you can see the inside of the artery is completely filled with cells. These stain positive, many of these cells stain positive for smooth muscle marker. And the pink that's here is actually they're laying down collagen, and that cells have to lay down collagen because the cells that go in to open the lumen have to hold on to that collagen and then contract to open it back up. So we have, when we looked at the mice, the group of mice that we did, first of all of them had lesions like this in the arteries, and they were not present there in our wild type mice. But in addition, about a third of the mice died after a few days after we ligated the artery. And when we could see them before they died, they had stroke-like symptoms. And we're in the process of staining the brains and doing other studies to confirm that all the mice died of strokes. So here we have, with just a simple injury of the carotid artery, we do start to have strokes in the mice. And that the lesions that we're seeing in the pathology that we're seeing in the carotid arteries looks exactly like it does in the patient. So this turned out to be a great model to test the drug. And that's why I put things on hold. And we decided to take 6 months to see if we could improve outcome in our mouse models. And we did that. And this is just to remind you what the human lesions look like, and the mouse just looks like that. So here's our results from when we treated the mice. So once again, this is what we had in the control and SMDS mice. Here's the SMDS mice with treatment. First of all, none of the mice died of stroke. So we made a big difference in terms of outcomes of stroke. And then if we looked at the arteries, half the mice had no lesions. And here again, you can see this is the wall. This is the lumen. The lumen's wide open. It has just a few small blood cells that weren't removed during the fixation of the artery. The artery is bigger than it is in the wild type mice, but everything is intact. And then we had the other half of the mouse still did have those lesions. But what was different was, you can see here, there's the pink of the collagen, but you can see over here, there's a lot of red inside here, and that's actually blood flowing through the lumen. So although we didn't open the lumen up, we still changed it so that there was consistently blood flow through these lesions. So we can do away with we can prevent the 33% of the mice that have strokes. And we can, in the half of that, and then of all our mice, half have no lesions and half still have lesions, but there's blood flow through those lesions. So we also looked at the brain to see if we were affecting what's going on in the brain. And so here's the control mice at baseline, the SMDS mice at baseline, and our SMDS mice with treatment. And if we look down here, so if the arteries are blocked after this injury, then the arteries in the brain will remodel to maintain blood flow. And that what they do is they increase the size of the arteries that are already there. And so the lesions done here on the left side, so you can see these arteries are a little more in the control. They're a little bit bigger than on the unligated side. But you can see here that there's many more enlarged arteries in our SMDS mouse, both on the side, the left side where we did the ligation, but also on the other side. So there's something that's also disrupting flow on the other side. And then this increase is greatly reduced when we do the treatment, and it begins to look more like the wild type mice here. And we can go in and quantitate the increase in size. Here's the wild type mice with the vessels, and we can measure the diameter. And then here's our SMDS mice, and you can see the arteries are more prominent, they're wider. And then here's with the treatment, and we can actually Anita went in and measured the size of all these arteries, and it showed that there's more blood flow through these these arteries in the SDM mice, and that blood flow is decreased with the treatment back to what it looks like in the wild type. So here we have a model where you ligate you put the clamp around the artery. It causes these bad lesions to occur in the arteries, and it's decreasing blood flow into the brain such that the brain has to adapt by dilating up the arteries to maintain blood flow to prevent strokes. So this is what is happening in the mice that survive, but the SMDS mice that don't survive, they are not able to increase the blood flow to the extent, and they end up having a stroke. But with the treatment, we see that looks more like the wild type, that yes, the blood flow needs to be increased, but it's not nearly what was required in the SMDS mice. So in conclusion, and then one last thing is that we wanted to see if there was any change in the size of the aorta when we did this treatment in the SMDS mice. And you can see that, and we also looked at the control mice with treatment. And so even there's no difference in the size of the aorta in our SMDS versus control at this age. And you can see there's no change in the aortic root, and there's no change in the ascending aorta. So these mice, once again, were only treated for 3 weeks, and we want to do a long-term treatment, but it just in this 3 weeks time frame, it does not change the size of the aorta. So remember, we don't want to give a treatment where we prevent strokes in the brain, but we cause worse disease of other organs like the aorta or the lungs. So what our plan is going forward from here is to confirm that long-term treatment of the drug does not increase aortic and pulmonary disease in the SMD mice. We're starting that trial now, and we'd like to treat them over the next year and check the aorta and check lung function and make sure that we're not disrupting anything there. And then we also want to go in and see if this treatment alters the phenotype of the smooth muscle cells in the mouse itself. And that takes we can do due to amazing new technologies called single cell transcriptomics. And then we have other alternate treatment. We have that one other treatment that worked in the culture, and we also want to try that in the SDM mouse model, so that if this first drug does not perform as well as we expect, we can go forward with a second way of treating the patients, or even combine the two treatments in patients. And then we're going to be working over, now that we have these data, we're going to be working on imaging protocols and collecting data from blood samples to assess if there are change, if we give this treatment to SMDS patients, if it alters the smooth muscle cells in the patients. And once we have at least this data here and have an imaging and a blood biomarker that we can say is indicative that we're altering the smooth muscle cells, we want to move to the clinical trial. I know that everybody's anxious to get the trial going, but number one, as physicians, one of the things we never want to do is cause harm. And we're trying to be very careful to, number one, show that the drug works in culture, but also works in an animal model. And number two, show that it alters the smooth muscle phenotype in patients with SMDS. And we have a way to do that through imaging protocols and getting and collecting blood samples. And then with that information, I feel confident that we can go forward with the clinical trial. We're designing that right now, and we plan to keep you informed more frequently of our progress over the next 6 months. And so I just want to recognize everybody that's contributed to this work. Callie Kortner, Anita Kaw are the primary individuals doing the work that I talked about today. Mara Borio is the individual that took over for recruiting patients into our cohort of SMDS patients. Ellen had been doing it for many, many years, but Mara took over, and I apologize, Mara, I forgot to get your name and update the slide. And we have many other collaborators, including the people at MD Anderson and the University of Vermont and the University of Washington that have helped us with these studies. And we've also had many physicians refer patients to our studies, and we're very appreciative of that. And we really, really thank you for participating in our studies to date so that we could define the clinical history of the disease, so that we have that data to begin to compare what we are, at baseline, what is happening versus what happens to the patients with this treatment. And we have received funding from the Bureau Foundation, and really thank Nancy Patera and their family for doing fundraisers for our studies. And we do have a number of other patients that have contributed to our studies. And one family that recently gave funding is the Brandon and Wendy Johnson family that has recently contributed studies for us to continue working on the mouse model and begin to do the human studies in patients. So thank you very much, and I'm happy to answer any questions.
Okay, great. That was wonderful. We do have a few that were sent to me personally, and then a few in the chat as well. The first one I'll ask, because I think it's kind of a big picture question. Someone asked, how is this different from, say, gene editing? Why pursue this instead of fixing the problem in the DNA? If the cause of the problem is all this one letter change, why not fix that instead?
That's a great question, and thank you for asking it. So I think that gene editing will be possible in the future. I don't know how long it's going to take. We can currently take out somebody's bone marrow cells and edit it, then put them back in. And we can use that treatment successfully for sickle cell anemia and other blood disorders. We have not been able to go into multiple tissues to correct the cells in multiple tissues. So I know the group, Dr. Mussolino and Dr. Lindsay up in Boston are working on gene editing, and they're focusing on trying to correct the smooth muscle cells in the arteries. And I think that those studies are very important, and they potentially could really help with preventing the aortic disease. And actually, we have data that we are publishing in our mouse model saying that you don't even have to go in and correct every single cell to prevent the aortic disease. The problem with gene editing is that for these lesions in the brain, we think it's just 1 or 2 cells that actually migrate out of the wall and then just proliferate to fill up the lumen of the artery. So you're going to have to get 100% of the cells are going to have to be corrected to prevent the cerebral vascular disease. We'll have some studies in the next 6 months to prove that one way or the other, but I am afraid that that they will never reach that efficiency anytime soon with gene editing. So we have to have alternatives. And once again, the gene editing is not addressing the pulmonary disease, the GI disease, or the bladder disease. And we have some preliminary data that this drug will also improve the cells, that the smooth muscle cells that are in this system. So here we're giving you treatment that will go into every cell in your body and influence all the smooth muscle cells everywhere. And so what I sort of see in the future is that the individuals or the children with this condition undergo gene editing, and that will help the aortic disease, but then be put on a drug like this to help the rest of the smooth muscle cells. So I think we need both studies going forward, and it may get to a point where gene editing can affect every single cell in the body and reverse it completely. But I think that sort of treatment is a long way off. We're just not there with the technology yet. Not so much we can do the gene editing, but to get it into all the cells and do the correct editing we're not there yet.
Okay, please let me know if anyone has a follow-up to that, but I think that answered the question very well. Okay, next we have from the chat, how can we reconcile the vascular phenomena, the moya-moya-like disease, with aneurysm and dissection events? I guess this is another really big picture, fundamental question people have about this condition. It seems like these two things are kind of opposites.
So there is data to say that the treatment that we're giving will actually improve the aortic disease also. I sort of emphasized that we wanted to make sure that it didn't lead to the aorta growing more rapidly in the SDMA spots, but we really do not expect that based on already published data in another mouse model of aortic disease. So we're hoping this treatment will help the aorta and help prevent strokes and other cerebral vascular problems in the brain. I don't think this treatment will be a cure, but I hope it delays the onset of the complications and makes those complications much less severe. For the aorta, we do have a good treatment. We can go in and just fix the plumbing, put in a Dacron graft, and that prevents any of the problems, the life-threatening problems with the aorta. And that's one of the reasons why we're focusing on a lot of our work on what's going on in the arteries in the brain, because we really do not have a good treatment for that. And then, as I said, we'll be assessing the pulmonary function and really trying to determine if that makes a difference in terms of the pulmonary function also.
Okay, also in the chat, thank you for the talk, number one. Two, are you saying that the treatment might lead to long-term changes in smooth muscle cell behavior, so they stop acting like stem cells long after the clot is cleared? Would this occur everywhere in the body?
So we know from our studies in SMDS patients that the smooth muscles moving out of the wall into the lumen of the artery occurs in almost every artery in the body. So we expect that this treatment will prevent a lot of that movement of smooth muscle cells into the lumen. The reason why it shows up with problems in the brain is because the brain functions based on pulling oxygen out of the blood. And other organs can get their energy from other sources, so it's not so dependent on blood flow. And so I think the symptoms and complications are showing up mostly in the brain for that reason. But I think this treatment will help that movement of smooth muscle cells from the wall into the lumen in every single artery in the body. Also, many of the patients with SMDS have problems. They'll get clots in their arteries that are hard to resolve, and we think this will help resolve those clots. Many of the patients have even had to have bypass of arteries because there were recurrent clots that did not resolve in those arteries.
All right, one more. So this is talking about, you mentioned at the very start, and welcome to everyone. A number of people joined during the talk, so welcome. Please put your questions for Dr. Milewicz in the chat. You can also email me at the address that's in there if you prefer me to ask them anonymously, but you can also send them privately to me. So at the beginning, you mentioned that there are a few cases that do not have the same exact change of the arginine 179 ACTA2 change. So for these handful of other patients out there, and perhaps we'll learn about more in the future, how are we going to be able to extrapolate from this trial that this would also be successful for those patients, or would we have to do a whole separate trial just for the, one or two people who might have some of these other genetic changes?
So we've known for a long time that there's another change, arginine 258, that leads to the early onset aortic and cerebral vascular problems that SMDS patients have. They also have the patent ductus arteriosus, but not 100% like the SMDS patients do. And they don't have the urinary tract and the gut problems. I plan to include those patients in the clinical trial. I think that we have data, or Callie has data from her studies, that they have the same defect that's as in what's going on in terms of the differentiation that it occurs with the arginine 179 alteration. So those individuals with overlap, we'll go ahead and include them if the overlap involves the cerebral vascular, the pulmonary, or the aorta. There's a few of the patients, we had 5 patients with conditions that had unique genetic alterations that were not the typical arginine 179 alterations. And one of them just had the GI problems, but not the problems with the arteries in the brain. So we also see that sort of a variability.
Okay. Okay, I'm sure people will be happy to hear that. All right. So someone's asking about the age of when people could have this treatment. Would it only be for people who haven't had a stroke yet? Could it possibly help people who are older and have already, developed this moya-moya-like condition, who already maybe have had their aorta repaired? Or does it have to be done basically at birth to prevent this disease from occurring?
So we know that strokes can occur in SMDS patients as they get older, even if they weren't diagnosed with, problems with cerebral vascular disease as a child. So yes, we plan to include all patients, no matter whether they've had their aorta repaired or not, or whether or not they had a moya-moya-like changes in their cerebral vascular system. As I said, so the strokes that are occurring in the later, in the older patients are still ischemic stroke, which means blood flow is getting blocked in an artery. So we still think that this treatment will help prevent those problems.
That makes sense. Okay. Are you able to provide any information about what type of drug would be used in these trials? Are they experimental drugs or FDA approved? Is it okay to use them in children?
So the drugs are the particular drug that we're going to use is approved in children to very young ages, has pretty minimal side effects. And I would not have problems with giving my child this drug. It's not an anti-cancer drug. That's what we thought we would have to go to. But it turns out that we do not need to do that to really make a difference. And we also had some data that the anti-cancer drug may prevent the cerebral vascular lesions, but made the aortic disease worse. So those are off the table in terms of treatment, at least the cancer pathway we were targeting. So we switched over to focus on this treatment because it is, like I said, something that's already approved. It's relatively benign, and I think most of you would not have a problem taking it yourself or putting your child on the drug.
Great.
And I mentioned previously, I don't want to say what the drug is. We are putting the paper together now and hope to, and Anita's writing the paper about the successful treatment of the mouse model. And then all the details that I did not go into in terms of what's changing in the smooth muscle cells with this treatment. And so that will probably come out in the next 6 to 8 months. So I'm hoping to have things set up so we can collect the data as people start taking the drug going forward.
Okay. Will this treatment reverse aneurysms and other disease, or just keep what's already there from getting worse and progressing?
That's a good question. We don't know. It would be nice if it did reverse aortic disease, and in the mouse model, there was some data that it did, but I'm not sure if we can repeat that data in humans, and I was a little skeptical of that data anyway.
Okay, that leads directly into another question someone sent me, which is, does it ever happen that you see a treatment in a mouse and it works great, and then you go to humans and it doesn't work at all? Is that a thing that happens?
Absolutely, that happens. And so I'm not promising anything with this treatment. I think our mouse data are very exciting, but these are mice, they're not humans. And I feel comfortable going forward because we know it's not doing harm. We still want to do a long-term treatment in terms of the aortic disease. But at the same time, like I said, this is a drug that is physicians feel comfortable giving it to children.
Okay. Someone asked, this is just kind of a fundamental vocab question, but can you explain what cell culture is?
Okay.
What do you mean when you say that we're doing culture or something like that? What is that talking about?
Oh, good question. It just means that we can, and in terms, we can take cells from the mouse. Mm-hmm. We can take the aorta from the mouse and an aorta from a patient when they have aortic surgery. Nobody's donated their aorta to us outside of surgical repair for good reasons. And then we take them into culture, and we can get the smooth muscle cells that are there in the wall of the aorta to grow in a tissue culture plate. And we can get them to grow, and we can grow them up to a large number of cells that we can study. And then we can actually treat the cells in culture with the drug and see how it alters the smooth muscle cells. So that's a really good question. So we've done that with cells from the mice. And I showed some of that data that it really stops the migration and really I didn't show the data to say it takes it from being more into more differentiated smooth muscle cell. And we can explant the cells from the patient's aortas. And then we can also, to look at that, what's going on during development, we can take a piece of skin from somebody and put that into culture and grow out a cell called fibroblasts. And that's the cells you have in your skin. And then through reprogramming of the cell, we can make it a stem cell and then study the differentiation of that stem cell into a smooth muscle cell. And Callie's worked out all the protocols to do this and has very, very strong data as to what is happening with the SMDS cells and why they're not differentiating correctly. And then Anita's taken those cells along with the cells from the mice to study, can we reverse that problem with differentiation using different drugs? And why is, it's not differentiating, but what actually is preventing it from differentiating correctly? And how do we push differentiation? So it's been a lot of hard work by Kelly and Anita in the laboratory, and they deserve a lot of kudos. They've done fantastic work. Callie is joining us on faculty. She'll be staying here to continue these studies. thank goodness. So we will have even more data in terms of the developmental problems. And then Anita is getting both her MD and her PhD. She needs to write this paper before she, and then she will have finished her dissertation, her PhD, and she has one more year of medical school to complete, which is going to be starting here soon. And then she's going on to internship and residency and plans to be a cardiologist. So
Wonderful.
yeah.
We have a few questions that are kind of just about SMDS in general. Are you okay with me asking those? Okay. Feel free to, if you want to hear more about the trial, of course, add those in, but I'm going to just go through these since we have a little time. Someone asking, does everyone with SMDS end up having a stroke? What if you're already a teenager? Does it mean you're still at risk?
No, not everybody with SMDS end up having a stroke. And we know that these strokes tend to occur mostly in the younger children. And then there's strokes that occur as people get, as SMDS patients get older, but we don't know the frequency. Okay. We have asked people that are in our cohort to let us get updates every couple of years in terms of how they're doing, and then also let us know if they've had a problem like and what we call an event, and that would be, repair of the aorta or any sort of stroke or other problems.
Okay. Speaking of repair of the aorta, is it true that people with SMDS should not get an artificial valve if they have a choice? If they're having, I'm thinking people are talking about, they have a planned repair of an aortic aneurysm happening. Sometimes people need to have an artificial valve put in when the surgery happens. And so they're asking about that for this condition.
Yeah, so from what we know, the valve works quite well in people with SMDS. But when the surgeon goes in or gets ready to plan the surgery, they will look at the valve and make the decision whether they should spare it or not. Okay, so my recommendations for anybody that's contemplating surgery is, number one, they go somewhere that does these surgeries routinely. This is a technical procedure, and so you want somebody that does aortic repair, and in particular, aortic repair where they can leave the valve in place. And the more a surgeon does that type of repair, the better they are technically. And the data says the lower limit is 20 of these repairs per year. I personally would pick somebody that did a lot more than 20 per year. And so if you have any questions about where to go, please contact us and we'll refer you to some sites that we know can do good aortic repair, and particular that valve sparing repair. The reason if the valve's normal, the reason we want to leave it in is because once you have a mechanical valve, you have to go on anticoagulants. And that is sort of like almost replacing one problem with another, chronic disease, because you have to have your clotting done routinely. You have to watch what you're eating when you're on anticoagulants. So it's just much easier long-term if you leave the valve in place.
Okay, since we only have a few minutes left here, I thought it would be a good time to talk about what people can do now in preparation of hopefully having this trial occur in the future. And one great thing is, if you're not already in Dr. Milewicz's research program, please contact them. The email address is mac@uth.tmc.edu, and you can get enrolled in the registry there. You can do it all virtually from your home, so it doesn't matter if you live in the US or abroad. As many people affected with this syndrome as possible is the best thing we can have. So she's just put it in the chat there again. So if you're not sure,
tomorrow we'll follow up with you.
Yeah, if you're not sure, just send an email just in case, just to check that you're in there, and that in case you've had an update to your email, your phone number, or whatever, maybe they couldn't reach you.
Additionally, I just want to say that I go to a meeting in Europe in about 10 days, and I'm really going to make sure that we've captured the majority of patients in Europe too. for these future studies.
That's great. And if you did not get an email directly from me, Ellen at the John Ritter Foundation, and you want to be on this email list for future of these events, please also reach out to me and I will make sure you're included there. We are going to be having another SMDS specific meeting in June, and I will be putting info out on that when we get a little closer to that with another expert on a sort of different aspect of this disease. So please get plugged in with us from all the ends if you haven't already. With that, thank you so much, Dr. Milewicz, for your time today. I'm sure everyone's really excited to hear about the progress. It's pretty incredible what's happened in the past few years, or the past 10 years. About the syndrome has been first described. We've gone from not even knowing what caused it and not knowing what all the features are to possibly investigating therapies for it. So yeah, thank you so much for your time today. And feel free to contact us if everyone's saying they're grateful in the chat to you for your time. So, and to thank you to Dr. Kortler and to Anita too for all your hard work on this project.
Good. Thank you, Ellen. Thank you, everybody.
Thanks. Take care, everyone.